Two implants placed mostly in this.
Yes, yes. So single implant, the doubt is clear, no? So when the mesodistal distance is more, say 14 mm, you have to place 2 implants. So here lot of challenges come. The implant should not touch each other, the implant should not touch the natural tooth. So definitely you should not select more than 4. When you are placing 2 implants, it will be definitely less than 4. Okay, either 3.75 or 3. Okay, or 3.5 or 3.7. 3.5 is available from Redis, 3.75 is available from Bioline. I think 3.7 from Simpladent, KOS available.
When placing 2, 1 pore is mandatory and the next we should reduce it.
Yeah, well, when you are placing only 1 implant in first molar, more than 4 or more than 4 diameter is must. When you are placing 2 implants, select implant diameter less than 4.
Okay.
Because anyway you are going to place 2 implants, if you put 4, the inter-implant distance may get compromised. Okay. So mesial, what implant you have to place? Mesial, definitely I will prefer compressive, because there is no second cortical here for the implant to engage. Okay, if you put a BCS, it will be sitting inside the intramedullary bone. So whenever you are placing basal implant, make sure it gets engagement in the cortical bone, otherwise you don't get stability. So mesial implant, better keep it as a compressive implant. Distal implant, if you tilt distally tight slightly, you will get lingual cortical engagement, either with the compressive implant or from BCS implant, basal implant. If you combine a compressive plus basal implant, it is a good combo, because the basal implant is here, the diameter is only 2.8, the shaft, no, the neck diameter is only 2.8. So the inter-implant distance is much, we have a lot of freedom. Or you can select a one 3.75 and one 3.5 you can select.
So come again.
Yeah. See, combination of compression implants plus basal design for lower first 2 molar. Okay. The advantage is, if you use BCS, see this is a compression. Compression implant, the diameter here is more, but here the diameter is only 2.8. The diameter is determined by this blade diameter, this is 3.6, but however here it is 2.8. So the inter-implant distance is much better here. If you place a compressive implant this much big, the inter-implant distance reduces. Okay, so the mesial implant place compressive, the distal implant place a basal, getting engagement from lingual cortical. If you are not comfortable with doing lingual cortical engagement, do a compressive implant again, maybe 3.5, smaller diameter.
Here compressive and basal, but we cannot go with a lesser diameter, both compressive.
Yes, we can go. Yes, that is also an option. Yes. See, one is the compressive plus basal, another is compressive plus compressive. That is also one combination.
But most ideally, this combo, compression plus basal, is the best one.
Or depending upon the situation.
We can do it
Yes,
as a
yes. Depending upon the scenario, you can.
Minimum inter-implant distance for
2.
this is
2
mm.
2 mm. Money, madam. So if the patient is having 6 but only 7 is missing, this is 6, only 7 is missing. should we replace 7 or not? So this is a question. Okay. Most of the time it is not needed. 7 is not needed. There are certain situations where you can replace 7. When the upper 7 is present, okay, and when you have good prosthetic space is present, and when the 7 is healthy without any decay or periodontal issue, you can place implant here. If this is supraerupted, if this is decayed, if this is periodontally compromised, don't go for this. Carl Misch lists around 10 to 11 reasons why you should not replace 7. Okay, because there are a lot of challenges involved, because the nerve becomes closer, the bone quality is now poor, and the crown space is very less, and lot of occlusal problems develop here. Okay, so and the erratic chewing forces are more here, the risk of failure is more, and cheek biting may happen, tongue biting may happen, gingival irritation may happen, visibility is less for even surgery and prosthetic. So because of these reasons, most of the time we avoid 7. Even for yesterday patient, one side 7 was missing lower, right? The upper full mouth rehabilitation, we didn't tell 7. Okay. If at all you plan for 7, you can tell delay loading, that is a better option. Place 1 implant, lingual cortical engagement, and tell delay loading. Placing 2 implants in 7 sometimes may be difficult, because the distal implant may impinge with the buccal mucosa. Okay. Very rarely we advise 7. Okay, especially when the patient is having very wide smile, patient is showing, and some patients after removing 7, the cheek, they will feel the difference. After 7, my cheek has gone inside. For those kind of patients, you have to do 7. But whenever we are doing 7, we will inform the risk about it. Comparatively, the implant mobility risk is more with the 7. If that risk is okay, we can proceed. So if both 6 and 7 is missing, this is 5. The plan is 3 implants. It is very simple. Okay. No need for any 4 implants. 3 implants is enough.
Here what combination is?
Any combination depending upon the bone quality you decide.
Okay, here
Okay.
like as you said in the first, compressive and basal.
Yes,
like that.
as you go distally, you can select basal also.
The more distally you can go with the basal.
Basal.
Mesially, compressive is the best.
Yes. So this patient is for the full mouth rehab. So what significant feature we see in this picture? Reduced. The square face. Okay, the masseter is very much thickened. So these are the patients, they generate heavy chewing forces. And in ortho they call it as low angle faces. Low angle faces.